progresses, patients develop systemic egg fever, leukocytosis, and localized egg, right lower quadrant pain, rebound guarding, signs of
So basically appendicitis, if there's a rebound tenderness, it should be the diagnosis, I believe.
Therefore, atypical presentations of acute appendicitis can occur postpartum due to displacement of the appendix by the enlarged uterus. A 13-year-old boy is brought to the office due to dry cough lasting 2 weeks. The patient has also had low-grade fever, fatigue, and sore throat. Immunizations are up to date, and he received his tetanus diphtheria cellular pertussis booster 6 months ago. Temperature is 38.1 C, 100.6 F. Blood pressure is 105/65 mmHg. Pulse is 86/min, and respirations are 18/min. Oxygen saturation is 98% on room air. On examination, the patient appears tired but not ill. The neck is supple and without lymphadenopathy. The oropharynx is erythematous without exudates. Pulmonary auscultation reveals scattered crackles and rhonchi in both lungs. Cardiac and abdominal examination shows no abnormalities. Which of the following is the most likely cause of this patient's symptoms? Community-acquired pneumonia in school-aged children is frequently due to atypical bacteria such as Mycoplasma pneumoniae. The presentation is generally mild and often includes fever, prolonged cough, and bilateral crackles on lung examination. Like S. pneumoniae, non-typable Haemophilus influenzae, or type B in unvaccinated patients, can cause acute onset lobar pneumonia. However, this patient's prolonged course and bilateral disease make atypical bacteria more likely.
It's tough.
Respiratory syncytial virus is an extremely common cause of pneumonia in children age 5, but pneumonia from viruses other than influenza is rare in adolescents. An 18-month-old girl is brought to the office by her parents due to a rash and blisters that started this morning. Yesterday, the child was very fussy, particularly when her parents picked her up. The patient also had a fever that responded well to ibuprofen. This morning, the parents noted erythema and peeling skin around her mouth, axilla, and inguinal areas. Medical history is significant for otitis media 6 months ago. Vaccinations are up to date, and the patient takes no daily medications. Temperature is 39 C, 102.2 F. Blood pressure is 89/52 mmHg. Pulse is 145/min, and respirations are 28/min. Examination reveals an irritable child who cries with any attempt to move her. Superficial flaccid bullae and an erythematous rash are diffusely distributed over the body. Slight focal pressure to the back results in sloughing of the top layer of skin with underlying erythema. The face appears edematous, with peroral crusting. A single pustule is noted under the left nares, but no mucosal lesions are seen. Which of the following is the most likely diagnosis in this patient? Staphylococcal scalded skin syndrome. SS is a blistering skin condition most commonly found in infants and young children. The pathogenesis involves infection with certain strains of Staphylococcus aureus that produce exfoliative toxins, which disrupt keratinocyte adhesion in the superficial epidermis. Clinical presentation begins with a prodrome of fever, irritability, and skin tenderness. Generalized erythema is then followed by flaccid blisters bully located predominantly in flexural areas exposed to mechanical pressure, egg axilla, groin. Although peroral crusting can occur, mucosal surfaces are typically spared. Gentle pressure on the skin surface causes detachment of a superficial layer of skin, i.e., Nikolsky sign, and epidermal shedding exposes, underlying erythematous skin with a scalded appearance. In neonates, the source of infection is often the umbilicus or circumcision site, whereas in older children, there may be nasopharyngeal colonization or a primary skin lesion, egg pustule as seen in this patient. Cultures from the blood and potential infectious sources are obtained, however. The diagnosis is generally clinical. An intact bully are usually sterile. Treatment involves anti-staphylococcal antibiotics, egg, nafcillin, vancomycin, and supportive wound care for denuded areas. The mortality rate is low in children, and symptoms typically resolve in 1-2 weeks. 1, 2, 3. A 12-year-old girl recently diagnosed with idiopathic aplastic anemia is brought to the clinic for follow-up. Since her visit a week ago, the patient has developed red spots and bruising on her arms and legs. Laboratory evaluation reveals an absolute neutrophil count of 420 cells MM3 and platelet count of 7,000/MM3. She's given a platelet transfusion. Toward the end of the transfusion, the patient develops a rash on her chest that spreads to the rest of the body. Temperature is 37.2 C, 99.0 F. Blood pressure is 110/80 mmHg. Pulse is 90/min, and respirations are 18/min. Pulse oximetry is 98% on room air. Oropharynx examination is normal. Lung examination is unremarkable. Skin examination reveals a diffuse urticarial rash along the trunk and extremities, along with pinpoint, non-blanching, red macules and bruises at the extremities. The transfusion is stopped, and the patient receives diphenhydramine. Vital signs remain stable over the next hour, and the rash improves slightly. Which of the following is the best next step in evaluation of this patient's transfusion reaction? His hemodynamically stable patient developed isolated urticaria during a transfusion, which is consistent with an urticarial transfusion reaction. Urticarial transfusion reactions are common and typically mild. Pathogenesis involves histamine release due to preformed recipient Ig antibodies reacting against a soluble allergen in the donated plasma, or vice versa I. Donor Ig against recipient allergen. Symptoms are limited to hives and/or itching, and develop hours after transfusion initiation. In contrast, hives due to anaphylaxis typically occur within minutes of transfusion initiation and develop in conjunction with wheezing, angioedema, and/or hypotension. Management of an urticarial transfusion reaction includes immediate cessation of the transfusion and administration of diphenhydramine A. Antihistamine if urticaria is extensive. Diagnosis is confirmed if symptoms improve and no signs of anaphylaxis develop. The transfusion can then be resumed without additional evaluation. One, 2. A 40-year-old woman with a medical history significant for obstructive hypertrophic cardiomyopathy is scheduled for elective hysterectomy under general anesthesia due to large, symptomatic uterine fibroids and blood loss anemia. At baseline, the patient develops mild dyspnea with moderate exercise. She takes metoprolol. Blood pressure is 120/80 mmHg, and pulse is 65/min. Examination shows clear lungs and a mid-systolic murmur. There is no jugular venous distension or peripheral edema. During anesthesia, which of the following is recommended to prevent perioperative complications in this patient? Many patients with hypertrophic cardiomyopathy, HCM, have dynamic left ventricular outflow tract, LVOT obstruction that, when severe, can drastically limit cardiac output. The degree of LVOT obstruction is worsened by low LV blood volume, therefore, hemodynamics should be optimized to encourage high LV blood volume throughout the cardiac cycle, i.e., both end diastolic and end systolic.
I'm not gonna lie, I'm getting my ass kicked right now. Big unlucky.
High LV end diastolic volume, i.e. high preload, is encouraged by adequate hydration and avoidance of venous dilators, egg, nitroglycerin. Maintaining a relatively low heart rate is also beneficial as it lengthens diastolic filling time to increase end diastolic volume. High LV end systolic volume is encouraged by a relatively low stroke volume SV. A relatively low SV, whether from low contractility or high afterload pressure that the left ventricle must contract against, leads to blood being ejected during systole at a higher LV blood volume. This higher LV blood volume minimizes LVOT obstruction, allowing for more effective cardiac output. In contrast, if end systolic volume gets too low, there is a precipitous drop in SV, leading to severe LVOT obstruction. Hypertrophic cardiomyopathy, HCM.
I should make these abbreviations. I'm trying to get her to basically pronounce like things differently, like you know, to have her talk faster. Like hokum, she could say hokum, but this is actually obstructive. No, that's still hokum.
The degree of left ventricular LV outflow tract obstruction in hypertrophic cardiomyopathy is minimized by relatively high LV blood volume. High LV end diastolic blood volume, i.e. preload, is encouraged by adequate hydration and low heart rate. High LV end systolic volume is encouraged by relatively low stroke volume, which is facilitated by high LV afterload and low LV contractility.
Get my ass kicked.
A 66-year-old man comes to the office for evaluation of low back pain and difficulty walking for the past several months. The pain is worse with prolonged standing and is relieved by sitting. The pain is also less severe with walking uphill than with walking downhill. Medical history is significant for degenerative joint disease of both knees. The patient does not use tobacco, alcohol, or drugs. He takes acetaminophen as needed. His temperature is 37.2 C, 98.9 F, and blood pressure is 126/76 mmHg. His abdomen is soft and non-tender. There is no spinal tenderness to palpation, and a straight leg raise elicits no pain. Reflexes are 2+ in both legs. There is no Babinski sign. Dorsalis pedis pulses are full and equal in both feet. Which of the following is most helpful in diagnosing his current condition?
This is spinal stenosis, I think. Because he had shopping cart sign or some shit like that, where he just like leans forward. The differential diagnosis and everything I basically just based that upon was right here. Which I've literally never seen diagnosed.
A 68-year-old woman is hospitalized for right lower lobe pneumonia and treated with ceftriaxone and azithromycin. On the third hospital day, she develops acute shortness of breath and palpitation. ECG reveals atrial fibrillation with a heart rate of 150/min. Temperature is 39°C, 102.2 F, and blood pressure is 100/60 mmHg. The patient's heart rate improves following intravenous administration of diltiazem. Subsequent laboratory results are as follows.
I mean, I don't know if she said it better.
Diltiazem.
Yeah, diltiazem. I don't know if that does like T3, huh? Slower. I don't know if that like does this. This is for sure. Gotta be something like that or that. This is euthyroid 6 syndrome. What the fuck? What is a normal T4? Take your guesses not right now. What's a normal T4? Okay, I was gonna say like 1. It's actually like 5 to 12 here. Total, that is. Free T4 should be 0.9 to 1.7. And T3 should be around 100 to 200. That's easy. Get my ass whooped. So euthyroid 6 syndrome. Fuck my shit. Okay, let me just remove that. Let me remove this. Go away.
Thyroid function tests often are abnormal in patients with severe, acute illness. Euthyroid 6 syndrome (ESS) is a common pattern of thyroid function markers, often seen in hospitalized patients. A characteristic feature of ESS is decreased peripheral conversion of T4 to T3 by 5-monodiadenase. Factors that suppress conversion of T4 to T3 include caloric deprivation.
Yo, I've actually seen this. Like, the T4 is normal, TSH is normal, but the T3 is, like, low. Or, like, just one thing was off. I think it was a psychiatric patient. And, because they were like, oh my God, the TSH, they did a TSH and like TSH was normal or something. And then I was like, well, you could do a T3. They were just like wondering, like, they had T4, like, I don't even know anymore. Oh, this is interesting.
Factors that suppress conversion of T4 to T3 include caloric deprivation, increased glucocorticoid and inflammatory cytokine egg, tumor necrosis factor, interferon alpha levels, elevated free fatty acid levels.
Interesting. So if you'd be taking that like ibuprofen, maybe? I don't think. No. It's TNF, not. But caloric deprivation, okay.
Just as inflammation leads to low T3 levels, it also suppresses TSH, but not to the level seen with hyperthyroidism, although a low T3 level initially may be the only indication of ESS, as in this patient T4 and TSH levels may also decrease as the underlying illness continues. Many experts believe that ESS represents a mild, transient central hypothyroid state that functions to minimize maladaptive catabolism and severe illness.
I wish they had something to compare that to.
In general, thyroid testing should be avoided in hospitalized patients unless a clear indication is present, as in this patient with acute atrial fibrillation, possibly precipitated by pneumonia. Treatment of ESS with exogenous thyroid hormone i.e. levothyroxine does not improve clinical outcomes and is not indicated. During recovery, patients may experience a modest transient increase in TSH levels, which may be misinterpreted as subclinical hypothyroidism. Therefore, follow-up testing should be delayed until the patient has returned to baseline health. A 53-year-old man with alcohol use disorder is brought to the emergency department after being found in a park on a cold day in winter. He was unresponsive when found and was intubated in the field by paramedics. On arrival, his body temperature is 31 C88F, blood pressure is 77/48 mmHg, and pulse is 31/min. ECG shows sinus bradycardia and QT interval of 560 millisecond. Which of the following is the best next step in managing this patient's hemodynamic status?
Holy shit. Okay, well, actually, I wouldn't go with magnesium until until they're just fucking warmer, right? Because if you're colder, you're going to heart rate going to be slower. If your heart rate's slower, the QT interval may be like slower. But I would choose that if that. I don't know where that's coming from, but why not? Okay, fuck it. Sinus bradycardia, it does have, I would give that QT prolongation. From my understanding, QT prolongation in both men and females, like, I know that with like females, it might be like even longer. Males, it can be shorter, but like both of them around 550 is like the average between the two of those. Honestly, how low is that? Let's go! I was like, fuck, bro. Would I fucking give some cold ass dude fucking a blanket first or atropine first? I'd be like, bro, here's a blanket. Here you go. Now let's get this atropine in you. You fucking fuck. Oh my god, bro. As often, however, yeah, see, treat the hypothermia and then we get that fucking atropine. This is lit. That make me feel good that I could answer that one.
1, 2,
no, not
3,
the 1, 2,
4.
That's annoying.
A 5-year-old boy is brought to the emergency department with eye pain. This morning, the boy began to have right eye pain that did not improve with ibuprofen and warm compresses. Over the last few hours, he has had blurred vision. The patient has a history of frequent otitis media, multiple dental caries, recurrent sinusitis, and atopic dermatitis. He is allergic to mosquito bites, which results in urticaria. Temperature is 39.4 C, 102.9 F. Blood pressure is 100/70 mmHg. Pulse is 120/min. And respirations are 20/min. The patient is cooperative but appears tired and uncomfortable. Visual acuity is 20/70 in the right eye and 20/10 in the left. Examination shows conjunctival injection, proptosis, and periorbital edema and erythema on the right. Neurologic examination reveals limited adduction of the right eye and pain with extraocular movements. Fundoscopic examination is normal. The left eye is normal. There is moderate tenderness to palpation over the right cheek. Examination of the oral cavity shows a large, malodorous dental caries in the left lower second molar. The remainder of the examination is unremarkable. Which of the following predisposing factors is most likely responsible for this patient's condition?
Yo, I literally just had a question on this, and they said, I mean, I don't know about any of all of this. Wait, hold on. Wait, has a history of what? Interesting. Oh my god, bro. That kind of changes it. Fucking, oh my god. That's like, oh Jesus. Okay, he doesn't have urticaria. Anyways, blurred vision. Uh-huh. What the fuck, bro? Orbital cellulitis is the... Oh, my God, bruh.
This child has pain with eye movements, ptosis, ophthalmoplegia, and visual changes, findings consistent with orbital cellulitis. The most common risk factor for orbital cellulitis is sinusitis, particularly of the ethmoid or maxillary sinuses. Patients may have purulent rhinorrhea, fever, and facial pain, such as the right cheek tenderness in this child. The proximity of the sinuses to the orbital space allows the contiguous spread of bacteria, egg Streptococcus species, Staphylococcus aureus during episodes of severe sinusitis. The subsequent intraorbital infection causes inflammation of the extraocular muscles, ophthalmoplegia, painful eye movements, and orbital fat ptosis.
Damn, they want a CT? That's crazy, bro. Oh. I don't know. They kind of sound like they want a CT. I really want to say just the paraorbital edema should have given me the diagnosis. I do know that paraorbital edema is rare. Who knows? I'll come back to that. I don't know. If you know, let me know.
A 76-year-old woman comes to the office for follow-up after being seen in the emergency department for a fall. She tripped on her cane, which she uses intermittently for long-standing knee osteoarthritis, and fell while getting out of bed at night. The patient was unable to rise for several minutes following the fall. Evaluation in the emergency department revealed no fracture. Before this episode, the patient had sustained 2 similar falls at home in the past year. She did not sustain any major injuries or seek care from a medical provider. She lives alone and has a caregiver who assists her daily with meal preparation and grocery shopping. Medical history also includes hypertension, for which she takes an ACE inhibitor. Blood pressure is 159/87 mmHg sitting and 153/79 mmHg standing. Pulse is 83/min. The patient is alert and fully oriented. Muscle strength is globally decreased in the upper and lower extremities. Gait is slow but without evidence of ataxia or a limp. Examination of the heart and lungs is normal. Which of the following should be performed next to reduce this patient's risk of falls?
I would do that if she had a lower heart rate. Ooh. That's a possibility. But no, this, you know, like, ooh, maybe. She tripped on her cane. I mean, that's tough. Man. Fuck. I was gonna say, like, to prevent falls, we could fucking do some, core strengthening exercises, man.
Falls are a major cause of injury in older adults, resulting in injury, prolonged immobilization, and functional decline. This patient has multiple fall risk factors, including prior history of a fall, decreased muscle strength, and history of chronic conditions, egg, hypertension, osteoarthritis. All patients who have fallen should undergo a multifactorial risk assessment that includes screening for sensory disturbances, which are a major underlying contributor to fall risk in the elderly. For example, age-related declines in proprioception affect balance, leaving patients with increased reliance on visual input. Diminished visual acuity, including dark adaptation, can substantially elevate fall risk in dark settings, as in this patient who fell at night. Therefore, all patients who sustain a fall should have visual acuity screening and appropriate corrective eyewear. In patients who have sustained previous falls, supervised balance and strength training, a home safety assessment typically performed by occupational therapist, and vitamin D supplementation are recommended to further reduce risk of subsequent falls. Use of assistive devices, such as canes or walkers, is not associated with reduction in falls and may increase risk, tripping over device.
This is some bullshit. That's what this shit is. So, how do you do balance correction? Did they say that? Yeah, that's what I said right there. So, home safety assessment, who's gonna do it? An occupational therapist? Fuck you. I know occupation, bro. Ain't no occupational. I don't know about that. I ain't ever see an occupational therapist like do anything that wasn't absolutely necessary. Because we ain't getting enough of them. I think. I'm not sure. I don't really know what I'm talking about, to be honest. Yeah, so that's actually kind of funny. If you like give them a cane or walker, it doesn't actually help them with falls. Fucking these motherfuckers will just trip on it some more. Damn. Oh, that's hilarious, bro. I don't know if I want to like So basically you need a strength and vision assessment. I guess that's like my best way to like put this into a card. It's like elderly patient keeps falling. What's going to be a part of your physical examination? So they infected.
1, 2, 3. A 73-year-old man is seen in the hospital due to severe left facial pain and inability to fully open his mouth. These symptoms began earlier today, 8 days ago. The patient underwent a laparotomy for intestinal obstruction. The procedure went well, and he has had several bowel movements since the operation. Medical history is significant for dementia and colon cancer, which was diagnosed 5 years ago, and is currently in remission. The patient resides in a nursing home. Temperature is 38.9 C, 102 F. Blood pressure is 150/80 mmHg, pulse is 90/min, and respirations are 16/min. Examination shows swelling, erythema, and severe tenderness in the left preauricular area. Laboratory studies reveal a white blood cell count of 15,600/mm3. Which of the following would most likely have prevented this complication?
The fuck? You're telling me he has tetanus? That's wild, bro. Where the fuck did he get tetanus from? I don't know what the fuck that is. That was 8 days ago, though. Bro, like suppurative parotitis? Bro. Like the fuck is this? What? What the fuck is is a trismus?
Comma trismus.
The fuck is this? What the Who the fuck going on with this shit, bruh? Bro, this shit fucking mollywopping right now, bro. Oh my god, bro.
Suppurative parotitis.
I just don't know what the fuck that is, bro. I think. Okay, so this might be the card right here.
Suppurative parotitis often occurs in elderly postoperative patients.
Damn, this shit wants to make this shit makes me want to brush my teeth right now. Alright, fuck this shit.
A 7-year-old boy is admitted to the pediatric intensive care unit PICU due to clinical suspicion for sepsis. The patient's parents agreed to let him participate in an ongoing clinical study to assess the utility of IL-27 in predicting bacterial infection among patients with bloodstream infections who are admitted to the PICU. A blood sample is obtained and reveals an IL-27 value of 5 ml. A previously published study that compared several cut points for IL-27 with positive blood culture showed that an IL-27 value 5 ml has a sensitivity of 26% and a specificity of 95%. In considering how this patient's IL-27 value might influence treatment decisions, which of the following conclusions about the study results is correct?
Bro. Fuck me and my shit, bro. I'm just gonna fucking come back to that one. I mean, I don't know, bro. I don't know. The fuck does bitch take, bro? Why am I like so dead in the head, bro? Like I used to know things, but this fucking block right here making me feel like a bitch. What the fuck? Like what? I was like, what? This shit glaucoma? What? They getting glaucoma? What?
Acute angle closure glaucoma, ACG,
Like,
is a
like, which one of you fuckers are honestly gonna tell me y'all heard about this trihexafenadol?
trihexafenadol.
Like,
42.
and know that this shit causes acute angle glaucoma, bro. Bro. Damn, bro. You gotta get Dr. fucking Flockin' Knockin' up in this bitch. Fucking Jonathan. What a meme.
1, 2,
You
3.
fucking bitch. I'm not in a good mood
A
right now.
23-year-old man is brought to the emergency department due to generalized weakness and abdominal pain. 1 week earlier, he began a diet challenge that involved a juice cleanse and exclusive consumption of raw vegetables. He does not use tobacco, alcohol, or illicit drugs. The patient's mother has hypothyroidism, and his father died of lung cancer. Temperature is 37.8 C, 100 F. Blood pressure is 110/70 mmHg. Pulse is 110/min, and respirations are 27/min. The oral mucosa is dry. Laboratory results are as follows.
I don't know how that does that. I don't know about that, bro. Oh shit, what the fuck? Oh dude, this guy has diabetes? Wow. Bro, dude, this dude has type 1 diabetes. Bro, do you see it? Do y'all see it? Y'all see it? Oh my god. Oh my god. Wow. Wow. That shit, bro. Easy clap. I don't even need to explain that one.
A 45-year-old man comes to the office due to exertional dyspnea and fatigue. The patient spends most of his time indoors because of his symptoms. He has end-stage renal disease due to glomerulonephritis, and 6 months ago he began hemodialysis via an arteriovenous fistula. The patient has stayed close to his dry weight, and his hemoglobin has been maintained in the desired range with iron and erythropoietin supplementation. He is afebrile. Blood pressure is 160/60 mmHg, and pulse is 100/min. Regular. Oxygen saturation is 96% on room air. The right arm arteriovenous fistula is distended with very strong pulse augmentation. Carotid upstroke is brisk. The point of maximal impulse is displaced to the left, and a soft systolic murmur is heard over the cardiac apex that does not change with the Valsalva maneuver. Scattered ralls are heard at the lung bases. The extremities are warm, and there is trace peripheral edema. Which of the following is the most likely cause of this patient's symptoms?
I definitely was gonna say like, ooh, I guess maybe. Oh, bro, the only thing I could have crossed off was Hokum here. Bro, I guess. What? The fuck is this? But what am I looking? Bro, he has Hokum? What do you mean? No, it's what? What am I looking at? Like Hofum? Oh, a 15-year experience, bro. Bro, what is going on, bro? I never get my ass kicked this hard. Like, look at this. Oh my god.
A 32-year-old woman with bipolar disorder comes to the office for follow-up. The patient was diagnosed and treated for a manic episode at age 29 and has been stable on a combination of lithium and risperidone. Her mood has been fine overall, but she has been stressed about work. After a staff meeting a few weeks ago, her supervisor said she appeared angry because she was repeatedly frowning while others were presenting. Since then, the patient has been increasingly self-conscious and has started eating lunch alone at her desk. Temperature is 37.0 C, 98.6 F. Blood pressure is 132/78 mmHg. Pulse is 72/min, and respirations are 14/min. Physical examination is unremarkable except for occasional grimacing and slow inversion and tapping movements of her right foot. Lithium level is 0.9 mcl normal, 0.6 to 1.2. Which of the following is the most appropriate next step in pharmacological management?
So this is like your call when it comes to. This is your call, but basically extrapyramidal side effects of atypical antipsychotics. That's tough because she's stable on this bitch. She's stable. And you can't not make a bitch stable, if that makes sense. So I'm thinking like you treat the symptoms as needed. But it seems pretty like, you know, okay, that's like, that's totally fine. Like, I'm totally okay with missing this one because I know that I would have done that, but I know with like psych, once you have them on the correct dosing to be like stable, you don't want to, and I've personally seen it, you don't want to like fuck with that. Okay, all right, so fuck me then. Literally fuck me then. Fuck my shit. Fuck my shit. Oh, I have a little sound to play for you guys on how I'm feeling right now. seriously though, bro. How much? Like that's like literally, yeah.